Hey there everybody, how's it going? Today I'm going to go over transcranial Dopplers. Transcranial Dopplers are quite easy once you learn how to do them. The protocol is quite simple. You just have to follow a few steps. You might encounter some problems on patients who have thick skulls, but other than that, it's pretty straightforward. I'm going to go over the techniques and then do some case reviews, okay? Alright, so the lecture objectives are going to be anatomy review. We're going to go over the technique and then some pathology and case reviews. The advantages to transcranial Doppler is that it is non-invasive, it is portable, so it can be performed bedside. It is repeatable. The cost is better when compared to MRI and CT, and it has shown effectiveness. The transducers you're going to use for a transcranial Doppler are going to be a sector type transducer that can go down to 2 to 3 megahertz. These are the ones we're going to use for imaging and color Doppler. When transcranial Doppler was first being developed, it was used with these non-imaging transducers, which were a single element pulsed transducers. So here's a non-imaging system. In order to use these, it requires extra training. It's also used in continuous monitoring. They're relatively inexpensive when compared to ultrasound machines. They print out a detailed worksheet with all the values, and it helps your auditory ability to hear changes in velocity. Okay, indications for the exam are, a common one would be sickle cell disease screening for stroke risk, detection and monitoring of vasospasm in patients with subarachnoid hemorrhages, to confirm brain death, to detect circulating cerebral microemboli, the assessment of intracranial pressure in hydrocephalus in young infants, assessment of hypoxic-ischemic encephalopathy, and to assess the patency of the superior sagittal sinus. Here you have a diagram of the aortic arch. You have your arch right here, your brachiocephalic trunk or innominate artery, which bifurcates into subclavian and right common carotid artery. The left common carotid artery is usually solo, and then the left subclavian artery. The aorta typically has 3 branches. Some people have 2. There's some variations in this anatomy, but this is the main anatomy seen in most people. Here's another diagram. The aortic arch would be below here, and then you can see the brachiocephalic, which bifurcates into right subclavian and right common carotid artery. Off the subclavian, you have the vertebral arteries that come off on both sides. And here's your left subclavian and your left common carotid artery. This diagram, this is me. I should have shaved a little bit before I did this diagram. LOL. Okay, so the internal carotid artery is divided into 4 main sections. It's further divided when you're talking about gross anatomy or cerebral angiography. But these are the 4 main sections, which would be the cervical part, which is obviously the part that's in the neck. The petrous portion is the part that courses through the petrous portion of the temporal bone. After that, you have the cavernous section, which includes the paracellular portion and the siphon. And right above the siphon is where the ophthalmic artery originates. And then you have the intracerebral portion right here. So this would be the siphon right here. And then you have your ophthalmic artery that comes here. Once it goes into the brain, the ICA terminates here and bifurcates into anterior cerebral artery and middle cerebral artery. So once you get to the siphon, you have the ophthalmic artery. And here's a ultrasound image. Here's the globe. The ophthalmic artery can be seen here. And then these are ciliary branches right here. Now onto the circle of Willis, which is the main portion of the exam and a very common anatomy structure to many people. It's named after Thomas Willis, who was the first person to describe it in the textbook. It is it's a vascular ring that are all connected. So if one part of a structure is obstructed, you can have collateralization from another part that's anastomosed to it. The circle of Willis is only the anterior cerebral arteries, the anterior communicating artery, the posterior communicating artery, or the PCOM, and then the posterior cerebral artery. So the middle cerebral artery is not considered part of the ring. I mean, it is continuous with it, but it's not considered part of the ring. And there you have your circle. Here's an underside view. So you have a transverse view looking from below. The internal carotid arteries will be coming in from below, and then it becomes the middle cerebral arteries and then the anterior cerebral arteries. Again, you have the anterior communicating or ACOM, the PCOM, and then the posterior cerebral arteries with the basilar right here. And here you can kind of see the posterior communicating arteries are usually not visualized with ultrasound as they're too small, as is the anterior communicating artery. It's somewhere here. And then the two anterior branches of the ACAs are right here. You have your middle cerebral arteries on both sides, anterior cerebral artery, and then your posterior cerebral arteries. There is, just like the aortic arch, there's anatomic variation to the circle of Willis. A complete circle is only seen in approximately 35 to 50% of the population. Common variation would be hypoplasia of the posterior communicating artery, as you can see here. Or here is absent. Or actually, this would be the P1 segment of the posterior communicating artery. This would be a hypoplasia right here. Another variation would be a common ACA, common anterior cerebral artery, which is also called an azygos anterior cerebral artery, which is just one anterior cerebral artery that then bifurcates. All right, so beginning with your exam, you want to start in the middle cerebral artery. It courses laterally towards the temporal bone from the bifurcation of the terminal ICA. And it is a very important artery, as 75 to 80% of the internal carotid artery flow goes into the middle cerebral artery. It has 4 segments, but the one we pay attention to with Doppler would be M1, which is the long segment right before it reaches the sylvian fissure. And flow is above baseline when scanning this artery. Then you have the anterior cerebral artery, which courses medially and anteriorly. It gives rise to the anterior communicating artery, which I said before you usually cannot see with ultrasound. It has 2 segments, which is A1, which is the part that comes off the terminal ICA. Okay, and A2, which is post anterior communicating artery. And then on this one, the flow is below baseline. So if you're scanning here, you have your transducer here in this part of the head. Your sound beam is coming here. This flow is going towards the transducer, so it's going to be above baseline. This flow is going away from the transducer, so it's going to be below baseline. The vertebro-basilar system, as I said before, the vertebral arteries come off of the subclavian arteries bilaterally, and then they join to make the basilar artery. It courses through the transverse process of the vertebral foramina. It enters the skull at the foramen magnum, and then both arteries become, as I said, the basilar artery. When scanning this vessel from your approach, here would be the back of the head. Over here would be anterior portion of the head. All this flow in both vertebral arteries and basilar artery is going to be below baseline because the flow is going away from the transducer. So here is another view. That's the same view from before. This is power Doppler. That's why it's encoded in red. Here is your Y-shaped structure, which are both vertebral arteries, and then the basilar artery going away from the transducer. So the blood flow is going to be encoded in blue and will be below baseline on spectral Doppler. The posterior cerebral artery feeds the occipital lobes and wraps around the cerebral peduncles. It has 2 segments, P1 and P2. Flow in P1 is above baseline and flow in P2 is below baseline due to the curvature of this artery. So you have your transducer right here. The flow is going towards the transducer and then away from the transducer. When we are scanning transcranial Dopplers, especially for vasospasm and sickle cell disease, we don't really scan the cerebral veins because we really don't have good windows to scan them. However, if sometimes we do transcranial Dopplers on young infants, if their fontanelles are open, you can see the cerebral vein, especially the superior sagittal sinus. Also in newborns, you can see the vein of Galen, and it's good to know where this is, especially with vein of Galen aneurysms. This is in a newborn infant. You can see the blood flow in the superior sagittal sinus and coronal, and this image is in sagittal. This is a good view if they're worried about thrombosis of the superior sagittal sinus. Problems of the cerebral sinuses are not very common, and if they do suspect something, magnetic resonance venography is superb in diagnosing these patients. Here was a study from Perspectives in Medicine, which shows that even though it's not commonly or routinely scanned, you can see the cerebral veins on very young patients. Here you have the deep middle cerebral vein. Here you have the transverse sinus, the straight sinus, and then on here you have the sphenoparietal sinuses. Again, we don't normally scan this. I just wanted to show you so you can see that you can scan these vessels. This is a midline sagittal view on an infant with B-flow. This is sagittal through the anterior fontanelle. Here you can see the internal carotid artery, and then it goes up and becomes the anterior cerebral artery, the pericallosal arteries, and here you can see the vein of Galen and also the superior sagittal sinus. So anterior cerebral artery here, same part right here, and then the vein of Galen right there. Parameters that we observe while scanning transcranial Dopplers are resistive index, time averaged mean of peak velocity, peak systolic velocity, and end diastolic velocity. Time averaged mean is, when they first started developing transcranial Dopplers, they would use time averaged mean, and almost all the literature focuses on this as well. As we know, the resistive index is peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. And things that can affect resistive indices are hemorrhage, edema, increased intracranial pressure, transducer pressure when you're scanning through the anterior fontanelle. If you press down too hard, you can increase the resistance. And these parameters increase normally with age. All right, so let's go over scanning windows. We do Dopplers also on fetuses for the MCA to rule out growth restrictions. On them, you just scan the middle cerebral arteries bilaterally, and you use a biparietal diameter type window, transverse at the base of the skull. In neonates, we use the fontanelles, and we also use the temporal bone. On children and adults, we use the temporal, the suboccipital, which is also called the transforaminal, the orbital through the eye, and the cervical or submaxillary window. We scan the patient in supine when we're doing the temporal bones. Once we're scanning through the back for the basilar artery and vertebral artery, you can either have the patient turn their head sideways or turn their whole body lateral, the cubitus. And we used the lowest megahertz possible in order to get a good Doppler flow. And we use a flashlight technique, or I like to say a joystick technique, because the face of the transducer pretty much stays in the same spot, kind of like of a neonatal brain, and you just angle your transducer left and right in order to get the windows. So here's a fetal MCA Doppler view, transverse baby brain. You can see the MCAs right here. In the first trimester, you're gonna have no diastolic flow, and for second and third trimester, you'll have diastolic flow, though not as much as a neonate or child. I will link in the comments the article for fetal MCA Doppler, so you can read up on that in more detail. In neonates and young infants, the anterior fontanelle is a very, very clear window in order to not only see the arteries, but to see obviously the cerebral parenchyma. You can see the anterior cerebral arteries, the MCAs, and the terminal ICAs. Here's another view in coronal. You have your anterior cerebral arteries. There's two there, but they're so small it looks like one artery. You have your middle cerebral arteries, your nice circle of Willis, and your terminal ICAs. Sagittal midline view through the fontanelle. You have your anterior cerebral artery. You see the vein of Galen right here. Also, you'll have the pericallosal arteries with all its branches. You can also see the superior sagittal sinus. Normal RI for neonates would be greater than 60, or greater than 0.60. As you see here, the RI is 0.84. All right, the temporal bone is important. It's where you do most of our scanning. Ultrasound is not very good going through bones. It usually bounces right off of bones, but the thinnest portion of the temporal bone allows 35% of sonic energy to be transferred in order to insinate the cerebral arteries. 10% of the population will have no penetration, so you can't scan those patients, or at least you won't be able to get any usable data on these arteries, which are at the base of the skull. You could still probably scan from posterior and get the vertebral and basilar arteries. Through the temporal window, you're going to get a lot of information from all these arteries, beginning with the middle cerebral artery. You want to begin most distally and then work your way medially in 2 mm increments. Once you reach the bifurcation, you'll start to get a bidirectional flow pattern. You can open your window, you can open your gate in order to get those two arteries really clear, and you'll get this waveform here, which is MCA and ACA. Once you're done there, you can begin scanning the anterior cerebral artery. You can take about 2 or 3 samples here, as it is a short segment of artery. The flow is going to be below baseline. And then you move on to the posterior cerebral artery, which has 2 segments, P1, which will be above baseline, and P2, which will be below baseline. The velocity is usually highest in the MCA and lowest in the posterior cerebral artery. As soon as you're done with that, you can angle inferiorly, staying in the same part of the temporal bone. Just angle inferiorly, and you'll get these 2 round structures, which are the terminal ICAs. So this is pre-bifurcation. Since these vessels are arranged vertically, you're going to get them in transverse in this section. Flow here might be above baseline or bidirectional, depending on what part of the vessel you're getting, as these vessels are quite serpiginous. The cervical ICA is common to anyone who does carotid arteries, carotid artery Dopplers. You have your bulb and then your internal carotid artery. You're going to have a nice waveform with a clear spectral window, which you're not going to appreciate on transcranial Dopplers, as we tend to use larger gates. The occipital window. So with the patient either with their head turned to the side or their body lateral to the cubitus, you put the probe at the nape of the neck, right below the hairline, and angle superiorly or cephalid. You can either go midline or try to go on the lateral portions of the neck and angle the beam midline. Depending on the musculature and the patient's position, you'll have to use those techniques in order to get the view. If they tilt their chin towards their chest, their muscles might get tighter in the back, and you might have a harder time penetrating. So try to have them lift their chin up a little bit and use different positions in order to get this view. You're going to get what looks like a Y, and the blood flow is going away from the transducer, so it's going to be encoded in blue, and you have your bilateral vertebral arteries. Flow in the vertebral and basilar arteries are going to be below baseline. The orbital view can be a little tricky if you're scanning a baby. They might not want you to scan on their eyes, understandably. You want to use a disinfected transducer and sterile gel, and just a sliver of gel. You just want to put a tiny film of gel and wipe off the excess, because too much gel might get into the eyes and cause some stinging. If they are older and they allow it, you can also use a Mederma patch, which is a clear patch used for topical medicines. Just place it over the eye and use that as a barrier while putting the transducer gel on top of the patch. Flow in the ophthalmic artery is going to be above baseline. This is from Advances in Transcranial Dopplers in the journal Radiographics. They show the arteries that they're scanning, the window, the depth from the cranium, the transducer orientation, flow direction as I've gone over, and then the mean flow velocities. In the MCA, the mean flow velocities for adults are going to be from 46 to 86. So again, in adults, mean flow velocity is 46 to 86 in the MCA and 41 to 76 in the ACA. Normal values in pediatrics are a little higher. Very early on, 74, 85. And as the patients get a little older, the values increase to almost 100 and then taper down in the later teenage years to 81 and stays like that and through adulthood. And then the peak systolic velocities are there as well. The range is 74 to about 90s, and then going back down to the 80s in adulthood, and peak systolic velocity 114 to 129. These values are going to be a little higher in kids that have sickle cell anemia. Here's a chart showing the distribution of velocities through age from early on. It goes rising and then decreases in a bell curved shape pattern. And here's a demonstration of that. On a 6-year-old, it's 185 centimeters per second peak systolic velocity, 114 time average mean. On a 12-year-old, it goes down to 104, 151. On a 14-year-old, peak systolic 109, time average mean 75. And on a 32-year-old, peak systolic velocity is at 86, time average mean at 54. So you can see how it goes. Starts from high. If I would have scanned somebody younger than 6, theirs would have been a little lower than this. But you can see how the pattern goes decreasing through age. Okay, hypoxic-ischemic encephalopathy happens from perinatal asphyxia. It's usually diagnosed when the patient has an APGAR score of 0 to 3 for greater than 5 minutes. They have profound metabolic acidemia. They can have seizures, coma, and hypotonia of the muscles. And it is associated with many conditions, including preeclampsia, maternal and fetal infections, drug abuse, and severe fetal anemia. Here's a newborn baby that had cardiac arrest at birth. On the first scans, on the ACA and the MCA, you can see the resistive indices were low. Normal is 0.6 and above. Then later on developed reversal of flow. You have to keep in mind the patient's cardiac status for this. Make sure they don't have a patent foraminal valley, as a patent foraminal valley will show diastolic steal in cerebral flow, which is not considered abnormal. Later on, the baby developed some ischemic changes here in the Sylvian area, in the Sylvian fissure area of the brain. You can see the hyperechogenicity here. Here's a baby that was born at 31 weeks. The mother had a cardiac arrest, unfortunately passed away. The baby was transferred to our hospital and was noted to have some changes in the thalamus and periventricular areas, hyperechogenicities, which are considered infarcts in the basal ganglia and paraventricular regions. The resistive indices were also low at 0.52 and 0.54. Unfortunately, this patient passed away as well. Here's another baby that was born with hypoxia. You can see the brain is hyperechoic, showing edema. There's a loss of differentiation between the gray and white matter. The brain has a smudged appearance with sulcal effacement. The velocities of the resistive indices were also low at 0.48 and 0.50. All right, so sickle cell disease is a main reason why we do transcranial Dopplers. It is a genetic hemoglobin disorder. The hemoglobin becomes misshapen within the blood cell and causes the cell to form a semilunar or sickle shape. These crescent-shaped cells are easily damaged and lead to anemia, severe pain anywhere in the body due to veno-occlusive crisis. These misshapen cells get stuck in the capillaries. It can cause splenic sequestration, which is pretty much the spleen atrophies and dies due to frequent infarcts within the spleen. Pulmonary hypertension, cholelithiasis or gallstones. Usually the gallstones, as opposed to being made up of cholesterol like most gallstones are, they're made up of bilirubin from the breakdown of the red blood cells, and can lead to stroke. 75% of these strokes are ischemic, 25% are hemorrhagic. In the New England Journal of Medicine in 1992, there was a trial called the Stroke Prevention Trial in Sickle Cell Anemia. It's called the STOP trial. It was performed on kids from 2 to 16 years old. The results of that trial showed a 92% reduction in stroke in patients who had elevated mean flow velocities and were treated with transfusions. The findings were so prominent that the National Institutes of Health released a statement requiring that kids with sickle cell anemia receive serial scans yearly. If the scans are abnormal, they will repeat them more frequently. Another part of the protocol is that they should be evaluated when they're in a healthy state, as opposed to when they're in a sickle cell crisis. Due to the fact that there's some variation in cerebral flow in kids with sickle cell anemia, you need at least 2 abnormal exams, at least separated by 2 weeks, in order to make the suggestion to go on to get an MRI to rule out ischemic stroke. When we scan these, when we do these Dopplers, we measure the peak systolic velocity and diastolic velocity and the time average mean, or the mean flow velocity. And a mean flow velocity of greater than 200 is considered in the ICA or MCA is associated with stroke. And as I said before, transfusing these patients based on the velocities resulted in a 92% reduction of stroke. And that was a great finding. So sickle cell screening should be performed, as I said right now, in a healthy state. The children must remain awake and alert during the exam. If they fall asleep, their breathing patterns change, they breathe less, and that can affect the velocities. Restless or agitated children may not be able to have the exam done if they are not able to stay still. And you have to keep in mind that some patients do not have a scanning window. So here are the parameters for the protocol. Normal velocities are mean flow velocities less than 170 centimeters per second and peak systolic velocity less than 200. If they're normal, they were repeated every year until the patient's 16 years old. Okay, a conditional exam would require the mean flow velocity to be over 170 but less than 200, and the peak systolic velocity to be above 200 but less than 250 in the MCA or terminal ICA. And an abnormal exam is one where the time average mean is above 200 and the peak systolic velocity is above 250. Another finding could be abnormally low velocities of less than 100 centimeters per second, or non-visualization of an MCA with an adequate window. That can mean that the vessel is occluded. So here's your conditional would be greater than 170 time average mean, greater than 200 peak systolic velocity, and abnormal is greater than 200 time average mean and greater than 250 peak systolic. Here's a 4-year-old male who in what exam had velocities above 200 peak systolic velocity and 238 on the other side. Subsequent exams on this patient were normal, but he was required to have an exam within a 2-week period to rule out. Here's a 5-year-old female, velocities above 275 in the middle cerebral artery. Here's a diagram from an article from Blood Journal where they were using hydroxyurea, which is a chemotherapeutic agent that increases red blood cell production. In one patient, they saw that they had increased velocities after they were transfused with hydroxyurea that lowered the velocities. This is a 19-year-old female who was quite sick in the pediatric ICU. She has sickle cell disease, of course. She had low velocities, however, as you can see here, 58 and 67 on the contralateral side. This patient had many other problems and developed cerebral hemorrhages and unfortunately passed away. This is from the Pediatric Radiology Journal, which showed a patient that had a time average mean of 240 centimeters per second and a peak systolic velocity of 300 centimeters per second. The MRA demonstrated marked narrowing of the right MCA, which is right here, and then the anterior cerebral artery too. This is a 16-year-old female with velocities in the ACA of 286 centimeters per second. This is peak systolic velocity. And they had a hard time getting the MCA on the right side, but the velocities were a little overestimated here, but about 314 centimeters per second. This patient ended up having ACA and MCA stenosis. Brain death is defined as the complete and irreversible cessation of brain function due to a total arrest of cerebral blood flow. So pretty much the blood flow, the brain stops receiving blood flow from the arteries and the tissue dies. This is usually diagnosed clinically. Nuclear medicine is also used to diagnose it. As you can see, there's no brain activity here. Transcranial Doppler has been also used to diagnose as an adjunct to diagnose brain death. Usually with brain death, you'll have sharp systolic spikes and reversal of blood flow, and it has to be repeated twice and shown over a period of 30 minutes. Here you can see no systolic flow and just reversal of blood flow in the middle cerebral artery. Here's another patient who had brain death, and you can just see these little tiny sharp systolic spikes and no other flow. Here you can see some sharp systolic spikes with some reversal of flow. All right, stroke can be divided into two categories, ischemic and hemorrhagic. Our ischemic strokes in children are usually caused by arteriopathies like moya, vasculitis, and dissection, also sickle cell disease. They'll have increased velocities in the stenotic region with color aliasing, decreased velocities distal to stenosis, and absence of flow and true occlusion. The window obviously must be optimal in order to be confident in that diagnosis. Hemorrhagic strokes occur in 1.4 per 100,000 per year in children, and causes for this might be sickle cell disease and cerebral aneurysm. Okay, so ischemic strokes are more common than hemorrhagic strokes. This is a patient, 8-year-old female, that upon Dopplering the cerebral arteries on the left, you have a normal flow with normal velocities. On the left, the flows are normal as well, though the peaks are a little blunted. When the ICAs were scanned, on the left you saw a normal waveform, and on the right, all you see are these sharp systolic peaks with no diastolic flow. This patient was found to have a dissection of the distal internal carotid artery. Here is a 5-year-old female that has normal flow on the right, and on the left middle cerebral artery there was an abnormal waveform which appeared pretty flat with low velocities. This patient had stenosis of the MCA. On this patient, you can see also a similar pattern with normal flow here and then almost flat flow on the left. They had a history of a tumor at the base of the skull that was removed, and in order to remove that tumor, you have to sacrifice the internal carotid artery. So usually these patients will have collateral flow from one side to the other. However, this patient had a ischemia due to low flow on the left side. As you can see here, the flow was at 23 centimeters per second. Time average mean was 19. Here's an 8-month-old baby who was referred for transcranial Dopplers. The patient had stroke-like symptoms. They did the TCDs. The TCDs were normal. Here's a coronal view through the anterior fontanelle. And this patient was found to have a aneurysm of the middle cerebral artery. And on this image here, you can see the clip. The patient was scanned afterwards for vasospasm, but never developed vasospasm. Here's a 16-year-old male who was found to have increased velocities in the right middle cerebral artery. This patient had moyo-moyo disease, which is arterial occlusions. Moyo-moyo is Japanese for puff of smoke. They have arterial occlusions, and then on cerebral angiography, they have these collateralizations that appear like smoke. And on the MRI, you see there's stenosis of the middle cerebral artery. Patients also with sickle cell disease can develop moyo-moyo. Traumatic brain injury. After a traumatic brain injury, a few hours after the TBI, the patient can have hyperemia, which will result in increased velocities, and this can last a few days. They can also develop ischemia from the edema and increased intracranial pressure. An initial time average mean of less than 28 centimeters per second corresponds to an 80% likelihood of early death. They can also develop vasospasms, which are stereostenosis of the cerebral arteries caused from hemorrhage and its byproducts. And vasospasm typically occurs within 48 hours after the subarachnoid hemorrhage and may last for 12 to 16 days. It is, however, uncommon in children. All right, a vasospasm, like I said right now, is an arterial spasm following a subarachnoid hemorrhage that leads to vasoconstriction, which in turn can lead to ischemia and necrosis, or lack of blood flow and death of tissue. All right, the destruction of red blood cells releases certain substances. Nitric oxide is one of them, and this substance can cause vasoconstriction. Some of these byproducts also can damage the endothelium of the cerebral arteries, which inhibits the production of molecules that can cause vasodilation to counteract vasoconstriction. It happens in 12 to 30% of patients with subarachnoid hemorrhage. It most often presents by the 4th day and can last up to 21 days following the initial hemorrhage. These patients typically have daily transcranial Doppler to monitor for vasospasm. Here's a chart showing the criteria for vasospasm. So here's the criteria for vasospasm. A time average mean of 120 would be considered a mild vasospasm. Above 200 and 250 would be considered severe. We also get the peak systolic velocities of the MCA and ICA and divide them to get a ratio. Ratios from 3 to 6 are considered abnormal. Obviously, the higher the number, the more severe it is. Here's an 8-month-old who had a traumatic brain injury. On the initial exams, you can see the velocities were very high. 335, time average mean of over 250. Peak systolic velocities of 449. The velocities go increasing, and then over time they decrease. 258, 226, and 154, which is considered normal. And over time, this patient developed cystic encephalopathy. Here's another 8-month female who was found to have a subarachnoid hemorrhage, which was thought to have happened from a fall. So in the first exam, you see the velocities on the right were elevated, 336. The left was normal. Eventually, the right went higher. The left went high as well, up to 504 centimeters per second. Finally, declining over time to normal values. It was later found out on angiography that the patient had an aneurysm. Here you can see the siphon, the ophthalmic artery, and this outpouching of the artery right here. So that was the cause of the subarachnoid hemorrhage. That aneurysm bled, which then led to the vasospasm. Okay, here's a newborn infant. And you can see a midline sagittal view of the brain, third ventricle here, and then this large cystic structure with medium level echoes. On Doppler, you can see flow. This is a vein of Galen aneurysm. Here is an infant that was on ECMO. The patient was thought to have a thrombus of the superior sagittal sinus. This is sagittal, no flow. You can see the color of the perforator veins, but no flow within the actual superior sagittal sinus. Here's in coronal. It looks like there's thrombus in there. The flow, it just turned out to be that the flow was very slow. This is B flow. You can see flow within the vein right here, and this is with regular color. Adding slight pressure to the fontanelle would increase the flow, and you would see the flow. So that was a false positive. And here you see the edema on the scalp of this baby. That was on ECMO, or extracorporeal membranous oxygenation for respiratory failure. All right, so to conclude, transcranial Dopplers are safe. The findings are reproducible. The exam can be done portable if the patient is in the ICU, and it is useful for monitoring several pathological processes. All right, everyone, I hope you enjoyed this lecture. I'm going to add this to a blog post that I made about TCDs, which already has a video, but the video is a short one, kind of going over the protocol. I wanted to include some pathologies as well. This is a longer video. I'll add it to the YouTube and to the blog. Alrighty, take care. Thank you.